on anything to date?
I'm really, really far behind. I've just finished chapter 3 and I'm taking the chapter 3 test. So
Okay, I can barely hear you. Can you?
Let me see if I can move it closer. I don't have a little box. I just have a big television screen.
All right, let me try turning the TV up. Okay, try again.
I am I've just finished chapter 3.
Okay, you just finished chapter 3.
Yes. So I'm very far behind. I'm sure the other ladies are further ahead, but I've been in touch with Amy to get questions to you, and they haven't come back to me answered. So I'm doing the best I can do and just plugging on.
Okay, all right. All right, and maybe the questions that you have that needed answers on, it might be on my end. I'll double check and see if maybe I missed communication and there's something outstanding. That could be.
Okay.
Traveling again.
Sure.
So I apologize. How about in Gardner? Any questions so far?
Oh, I am Gardner.
Oh, you are Gardner. Okay, sorry. I can't see who's talking, so.
Right. That's my fault.
No, that's okay. How about Mount Ararat?
I haven't watched the video on modifiers yet.
Okay.
So I know that I've already done that chapter, and it was a little difficult for me, but
okay.
I haven't watched your lecture yet, and I get a lot out of your lectures, so
okay.
I'm pretty sure I'll do fine.
There you are again. I'll just let you know with modifiers, I probably, I know I get a little off, not off track, but I probably go more than you want to hear. It's about an hour and a half. So
okay.
I had to do it in 2 sections, but I didn't do it so much sequentially. I grouped the modifiers, just to give you a preview. I grouped the modifiers into what I call families, or things that are related. Like there's some that are just specific for E&M, so I tackled those together. So the lecture, when you see the titles on the lecture, if you go back, like if there's something that you didn't get or didn't make sense, or maybe after we've done some of the CPT, something clicks and you want to go back, I labeled the lectures by the modifiers that were covered, and know that they're grouped together.
Okay.
If that makes sense. Okay.
Yep.
So E&M modifiers are together. Ones that deal with multiple providers in the same session are grouped together. Right. I can't remember what else would have been. Global surgery modifiers are together. So just and I talk about how those families are referenced too. So you're not just stuck with the number and the name, but you know like how they're grouped in a real life setting.
Okay.
Okay. Right. All right. So with that said, and you ladies can hear me okay, right?
Yes.
Yes.
Okay. So we'll dive into the evaluation and management services chapter. I'm just going to warn you ahead of time that it may take all 3 hours to get through this chapter. I'm hoping not, but it's a pretty extensive chapter, and it's also although I hate to admit it, it's a pretty important chapter because of the level of involvement. There is not a single solitary practice out there. Every provider, every subject matter, every specialty needs to bill from this section. So when we talk about evaluation and management services, these are everybody's experience this at some point in their life. You can't even come into the world without experiencing an E&M visit of some type. These are the reviews that the provider has, usually through a discussion. There may be some workup involved, but it's, like taking your blood pressure, checking your ears. It's what we would call non-invasive, all right? Most of it is performed through a face-to-face discussion. So this is E&M. I'm trying not, I don't want to put my opinion on that. I'll admit I struggle sometimes with this. Again, I've done this for 11 years now, and I have just recently, in the last few years, it's clicked. So if it doesn't right away for you, that's okay. All right, don't be turned off by it or think that you're doing something wrong, because it's while there are rules, different people can interpret things differently, okay? And we talk about levels, and it's very possible for people to read the same report and arrive at different levels. It shouldn't happen that way, but perception and interpretation, as many different providers that are out there, it's basically truly translating what they did and trying to assign value to a non-invasive and a conversation. Okay, so let's talk about, all right, so I'll do the best I can. Let's talk about the contents of the E&M section. So if you, in your textbook, that very first picture, if you will, under the contents of the E&M section, and again, in your CPT manual, remember that there are different chapters and they're divided up. So this is the very first one, even though numerically it starts with 9-9, it is at the front of the book. Okay, and your guidelines are here. There's some decision trees. All of this is very helpful. And you'll notice it's also one of the more extensive. Surgery doesn't have this many pages of guidelines that precede its section. So there are lots of rules that go along with that. And not surprisingly, as we talk about the subcategories in CPT, there are rules for each of those too, as well as the codes themselves. Okay, so what constitutes E&M services? I'm just going to go down through and talk about some of the headings and subheadings of the categories and subcategories that fall into this. So again, it will help paint a better picture of what we're talking about. Office visits, okay, going to see your provider. Hospital observation services, when the providers are rounding after surgery or before surgery or because of an illness, non-surgical related. Consultations, I'll talk more about that when we get closer to it, because not everybody recognizes what a consultation is anymore. Visits to the emergency department are separate from office visits. Critical care services, and again, there's a specific definition of what constitutes critical care, but those are a separate category. Things that happen in rest homes, okay, nursing homes, boarding homes, assisted living facilities, prolonged services, case management services.
You can see me, but I can't see.
Can they hear you?
Care plan oversight services or preventative medicine is another one. Things that are non-face-to-face with the involvement of technology, telephone services, online medicine, I know in my particular company we had the ability to
Yes.
call a group or call a physician, describe our symptoms, and they would for a fee give us a diagnosis over the phone. Okay, so it doesn't necessarily mean anymore that you have to go to a physician's office.
Okay.
Yeah.
Special E&M services, like I said, you can't come into this world without having one of these. Newborn care.
I'm gonna tell Kyle about it because he may.
There's a separate
Thank you.
category if it's neonatal. Okay, so we have critical care and intensive care services for the adult population, and then or everybody else, and then we have one specific to neonatals. Okay, those are our tiniest of patients. Care management services, transitional care management services, and advanced care planning. And we'll talk about what all of those are. But again, there's nothing invasive there. There's really no testing that's going on. Most of this is verbal with non-interventional type services that are happening. Okay, so one of the things that as you look at that list you may pick up on is there are 3 factors that are decided or will help decide the category of E&M that you're looking at. And that's the place of service, the type of service, and the patient status. Okay, so what we're going to do now is we're going to break down each of those categories for you. Okay, so the first one, place of service, is just what it sounds like. And if you get into the billing arena, it would seem like it's very simplistic, and there are only a few select places that you can bill from, and that's not the case. There are lists and lists of place of services that can be, right? Now, when your provider is billing, there may only be a handful that they're credentialed to bill in. Okay, a handful of place of services that they're able to bill for. So what are place of services? Things like offices, a physician's office, a hospital, emergency departments, nursing homes, rehab centers, okay? I'm trying to think, mental health institutions, okay? All of those are different places of service. Okay, now the type of service is the reason the service is requested or performed. So things that would constitute the type of service would be things like a consultation, an admission, newborn care, office visits, preventative medicine, okay? What am I missing? Type of service. Resuscitation services, and it goes on, okay? The next one is the patient status, okay? So there are 4 types of patient status, and they are new patient versus established patient, outpatient, and inpatient, okay? A new patient is defined as somebody who has not received any services from a physician or a partner, somebody else from that practice within the past 3 years. Okay, so let's say that you go to see an orthopedic person for whatever reason, and 2 years later, for your knee, and 2 years later you go back and to that same group, but you end up seeing a completely different doctor for whatever reason, you're no longer a new patient there. If you go back 3 years and 1 week later, then you're a new patient. Okay, it's a very fine line of what that definition is. Okay, so in the same group, it doesn't have to be the same physical person. It becomes an entity when we're talking about a practice or a group. So it's anybody in that practice in a 3-year period. Okay, established is the alternative. So within that 3-year time, within that same physical practice, it's an established patient setting. Okay. An outpatient person or patient is one that has not formally been admitted into a healthcare facility, or the patient has been admitted for observation, and there's rules about what constitutes observation. Okay, you cannot be admitted into a hospital and be qualified as observation status for a couple of days. Okay, even though you haven't physically moved, if they haven't gone through the process to formally admit you, you're outpatient. Even though you're physically in the building, physically in the hospital, it's the processes that have been put in place and the status that you then are assigned to. Okay, so don't be confused about that. Just because a patient might be in a hospital, they can still be in an outpatient status. Typically, outpatient, we think of ambulatory care centers, okay, instead of like a physician's office. But outpatient can still exist in a traditional hospital. Okay, an inpatient is one who has been formally admitted to a healthcare facility. Doesn't necessarily have to be a hospital. Again, can be a rehab center, a mental health facility, something of that nature. But the patient has been admitted, and they're there for formally. Okay, so those are the 3: place of service, type of service, patient status. And I can tell you that that would be the criteria. I don't know if I've shared with you before, but I tend to think in decision trees and flow charts. If I know I'm coding an E&M service, I'm going to go down, okay, where are they? What's the place of service? Go to that category and then narrow it down from there. What type of service are they performing? And what's the patient status once I'm in there? Any questions on that so far? Okay. All right. Okay. Medical records documentation. Patient information is located in the medical record, and I've probably used this terminology several times before, and I just want to be sure that the verbiage I'm using and the vocabulary I'm using is universal. We use it all the time when we talk about it. So information is referred to as documentation. So when you are coding something, you're looking at the documentation that's within the patient's medical record. Okay? Oftentimes in pro-fee coding, you're looking at one episode of care. When you're doing facility coding or hospital coding, you're looking at the full medical record that usually starts from the very first encounter that patient had with somebody at that facility until they are discharged and no longer under care at that facility. So you could be talking about a couple encounters, you could be talking about dozens of encounters, or in the case of somebody that's very sick, very ill, with multiple, you could be talking about hundreds of encounters. Okay? But regardless, we're talking about the documentation that the physician has provided for that service. Okay? There are 7 organizations, some of them we've talked about, some of them that we have not, but they've developed minimum documentation guidelines as follows. And this is under the E&M section, but again, this same principle, this same concept transcends through all of the other chapters that we'll talk about. There are documentation requirements in surgery, in radiology, in pathology, and in medicine sections, as well as anesthesia, although the anesthesia may look very different. Okay, so the 7 organizations are HEMA, okay, American Health Information Management Association, the AHA, the American Hospital Association, Managed Care and Review Association, the American Medical Association, which we are familiar with. They're the ones that publish our CPT manuals, American Medical Peer Review Association, Blue Cross Blue Shield, and Health Insurance Association of America. They've developed minimum documentation guidelines, and they're as follows. Now, as long as we've been meeting and talking, I'm thinking that you've picked up that there's one that's missing, and that would be the Center for Medicare and Medicaid Services, or CMS. Just because they're not listed here, they are still a major influence, and we'll talk about that as we go through, because again, as Medicare goes, so do most of the other commercial payers and what they require. Okay, so basically, and this part they all agree on. When you get to commercials and CMS and these 7 agencies, there may be some differentiations, but for the most part, they all agree on these. There needs to be a documentation that is complete and legible. Okay, and legible